Good morning, ladies and gentlemen. Welcome to this session, which is a sponsor session, and we thanks the GA for having made possible this session. That is something like speaking out of the box. This is not a classical subject, but we have two distinguished speakers that will try to address which could be the evolution of intensive care medicine. And it is then my pleasure, or maybe there is the possibility of launch a jingle that GA has prepared. They told me so. There is something like. If it is not ready, never mind. We start with our first speakers. And I invite Daniele to reach the podium. Oh, this is the jingle, you know. Very short one. However, as an introductory remark, seems to be very imaginative with the horizon this is extending. However, Daniele Bryden is going to speak about the efficiency through decreasing ICU admissions. I remind the audience that at the end of the session, there will be the possibility to ask questions through the chat. And I can at least translate what you write into the chat to and the microphone as well. It's up to you. So thank you, Daniele. Please.
Thank you very much. Thank you for inviting me to speak to you today. So I have no declarations of interest as far as the meeting is concerned, but the reason I'm speaking to you today is that I'm Dean of the Faculty of Intensive Care Medicine, which is the UK professional and statutory organisation for the practice of intensive care medicine. And we produced a report a few years ago on a new service related to critical care called enhanced care. And on the back of that, I've also jointly chaired some NHS England guidance on how you can use enhanced care for your perioperative surgical services. So it's that kind of development and background that I'm going to talk to you about briefly. What I want to do is really explain to you why enhanced care is an important service development, and try and show you how it can improve the efficiency of your service. And I'm also going to describe some models that have been developing within the UK. Will hopefully give you some idea of models for your own services in your own countries. So the first point to make really is around our population. There's a lot of focus at the moment around post-COVID and the patients that have chronic health needs or comorbidities that are waiting for surgery. But we knew even before the pandemic that the surgical population was getting older, and it was getting older faster than the UK population in general. So that by 2030, this data comes from a review of all surgical procedures within the UK. It's projected that about 1 in 5 patients over the age of 75 will need surgery, and about 15 to 25% of them will have major complications. So we have another wave of morbidity and demand impacting potentially on our intensive care units. The figure for the UK is now 7 million people that are waiting for a surgical procedure because of the impact on the pandemic on our health services. This is a real growth area in terms of demand. And when you actually look at the sorts of patients that are particularly going to be at risk waiting for surgery, this was again a review of 5 years of data from all patients within England who underwent surgery, and there were 4 high-risk diseases that were particularly associated with mortality and 90-day mortality. That's cancer, cardiac failure, liver disease and dementia. And they account for 2/3 of all our post-operative deaths within 90 days within the UK. They also account for patients having 1 in 13 procedures. Patients have at least one of these comorbidities. So really, we might feel, having got through the pandemic, that it's time to just kind of relax and go back to where things were. But the point I'm making really is that we can't, because there's another wave of activity about to make a demand on our services. Now, within the UK, for a few years now, we've had something called the Getting It Right First Time programme. This is a programme that originally started within orthopaedic surgery but has been rolled out to a lot of surgical specialties and also to critical care. And it's a process of peer information sharing, data analysis. And the idea is twofold. It wants to improve the quality of care for patients and improve patient outcomes, but it also wants to save money and reduce complications by looking at where processes are working really well and trying to share best practice. And this GIRF process showed that around the UK, there's a 2 to 3-fold variation in the number of patients who get admitted to critical care after the same surgical procedure. And that's not related to the case mix of the patients, it's related to unmet need in terms of provision of critical care beds. And we know within the UK we're under-resourced for critical care beds, but again GIRF has shown that there are 3 major determinants of whether or not a patient comes to critical care after their procedure. Yes, capacity is really important. Yes, actually having the resource of the empty critical care bed is important. But the most significant factor is culture. People's mindsets where they say, we've always done it this way. Why do we need to change? This is what we do for our service. So again, what I'd like to say is that there is an older, more comorbid population that at the moment doesn't need much critical care until things go wrong. But we know that they're going to be making those demands on our service, and those demands are going to increase. And we just can't keep doing what we're already doing. The World Health Organization has been running some temperature checks. It's run 3 in 2020 and 2021 around the pandemic. And it's identified a couple of key areas to overcoming some of those service disruptions. And I just want to draw your attention to the top 2. It's very much focused on the idea of new technology and alternate care pathways as a significant contributor to how we're going to address some of these issues. And the other is around health worker training and this idea that we have to look at our workforce and perhaps be less rigid about what roles our workforce or individuals within our workforce do, and look at how we blur the boundaries of the tasks and identify the patient needing a particular skill, making sure that somebody is there to provide that skill, irrespective of title. So this is coming direct from the top, so to speak, in terms of the WHO identifying these as areas as well. So the reason the faculty produced the critical care, or rather the faculty produced the enhanced care work, was before the pandemic. We had a demand within the UK to start looking at a route to how we could sort of tackle these issues. And the idea of enhanced care is it's a genuine bridge between the care that's provided on a critical care unit and the care that's provided on a ward. And we know that resource heavy critical care environment and the resource low environment of the ward is often a huge chasm for patients, and they feel very vulnerable as a result. So enhanced care is delivered in a ward setting, but it's delivered by an upskilled workforce who have access to a critical care team. So it's not critical care outreach if you run a critical care type outreach service, and it's not just ward level care. And the idea again is that it provides a recognition that patients are currently falling into a service gap, and we need to change our thinking and think about how we can address this service gap going forward. It is a mindset. So before the pandemic, we had services that were developed locally, very small scale in hospitals where they had particular problems. Now, since the pandemic, we have major teaching hospitals looking at addressing this service development by building new facilities or tech enabling their hospitals in order to be able to deliver this. And part of the reason for that is that there's recognition that patients need monitoring and support irrespective of the location they're in. So this idea of unfairness, that only people in a particular physical place get a particular level of support, and on another place they get less, that needs to be removed from our thinking. And we need to think about how we incorporate enhanced care into our hospital delivery. So just as an example, the perioperative enhanced care surgical population that I was mentioning earlier, patients have an adverse outcome after surgery either because of the procedure or because of other patient-related factors. Again, within the UK, our National Emergency Laparotomy Audit, all patients that have a predicted mortality above 5% are supposed to go to a critical care unit. But we also know from data that the patients that have a 1% mortality to 5% mortality are currently not getting anything above ward level care, but they've also got increased risks and reduced outcomes. So that's the group that needs enhanced perioperative care. And again, it very much depends on your hospital and your service, but it's about patients on a particular pathway that you can predict. So they may have a predictable length of stay, or they may have predictable care needs that you can protocolise and make sure that you've got appropriate guidance for. So for example, a patient that has hypotension with an epidural from the vasoplegia needs to have a little bit of pressor support. Your hospital currently can't do that other than a critical care unit. The idea of actually setting up an enhanced care service that will look at those patient groups and allow them to have the pressure support they need for a short period of time. And going alongside the enhanced care service is this idea of a clear protocol for patient deterioration, so that they're not being scooped up by the critical care, but you're recognising when the person is deteriorating and acting before that. The attractions for surgical services and the reasons why it's very popular in the UK at the moment is we've got a lot of on-the-day cancellations of patients needing critical care beds who are not being able to get their surgery, and with that backlog it's really quite a considerable impact on our services. So if you have an enhanced care as a service development, you can schedule your patients through that. You're not dependent on a critical care bed, but it also helps you to recognise that your patient group who wouldn't previously have got critical care but are deconditioned, they are going to get some enhanced level of monitoring and support. From the patient point of view, it's really attractive, because if you're waiting for your hip procedure and you have some comorbidity that says that people are not happy for you to have it on the ward, but you're continually getting cancelled because you're not considered to be a sufficient priority, that still allows you to have your procedure. And the data there below from the ICNAR, the Intensive Care National Audit and Research Centre, very clearly shows that as units get busier, patient outcomes get worse. So again, the concept for patients is attractive because they can get their procedure and they can get the quality of care that they need from people who are able to deliver it. Again, how many patients might be suitable? Well, again, it's as long as a piece of string, but it's estimated that up to 25% of patients needing elective surgery are not going to be able to manage in the future with just the current level of ward care that we're giving. But that very much depends on what your specialties are going through your hospital and what your population is. Again, the key thing is risk soaring. So it's linking into the perioperative medicine services, and particularly the pre-op assessment, and identifying the groups of patients that have protocolised care delivery that you can say they will be patients that will benefit from critical care. For medical patients, it's less clear-cut at the moment. It's not as well defined, partly because many patients have treatment escalation plans in place because they're older, frailer, they won't go to critical care. But there are often patients that do have some needs for critical care support, or the type of support that would be given in a critical care unit if they could get onto a critical care unit. And that's where enhanced care for medical patients is currently being considered. And again, that population is enormous. 1 in 3 have 5 or more health conditions when they come into hospital. And the group that's going to put the greatest demand on our health services going forward is those 85 years and above. So how do you staff it, you say? Well, to a certain extent, it again changed the mindset. It's not about the person and the role they have. It's about the skills that they have, what they can contribute to the skill set around the patient, and how you can identify groups of staff who could be given additional skills to help care for the patient. We know that about 40% of staff need additional skills training, and I think the COVID work that the ESICM did around its Space 19 and the way it identified rapid upskilling of staff, and also the recognition of the fact that you then have a reserve workforce that's potentially very helpful. I think that sort of shines a light on the way to go in terms of thinking about your staff skilling for the future. So the ideal enhanced care service is one that is really going to be defined by you, the users, in terms of identifying what you need for your patients. But it needs to have those things on the left that go with it. It needs to have clear leadership. It needs to have the patient pathways clearly demarcated and identified. And you need to be clearly linked into your critical care services and using information and data all the time to make sure that you're running your service correctly for the patients that you need. So in conclusion, I'd just like to say that an enhanced care service development can address those inequities of critical care provision and meet unmet need, because we're seeing that already in some parts of the UK. It does require an investment in your staff training and your infrastructure, and more importantly, it requires a significant change in mindset around how you're going to deliver your services. It's not critical care on the cheap, it's not a substitute for critical care, but if you predict your patients going through the right pathway, you will use your resources more efficiently and more effectively. And the Getting It Right First Time programme shows that that can save costs and improve patient outcome. Thank you.
We will have discussion in the end. It's okay? So the following speaker doesn't need to be introduced. It's Jean-Louis Vincent, that is known very well all over the world, and his honors are very well known as well. And Jean-Louis, if technical issues are solved, is going to speak in his imaginative ways on the efficiency through two things that may be contradictory: standardization and at the same time flexibility.
Thank you very much, Massimo, and many thanks to GE for having invited me to think about it more and present my thoughts to you. Because indeed, this is very different from speaking about sepsis or ARDS, and yet it's very, very important, especially for the future. Flexibility and standardization. I'll start with flexibility because we still have the COVID-19 experience in our minds, and we heard that flexibility was clearly very necessary in our organization. Flexibility means possibility to respond to changes, and we can find examples in many areas. At the bottom, we could think at restaurants that could increase the number of tables when there is more demand and decrease the number of tables when there are less people around. Or shops, that's perhaps even a better example. Before Halloween, they need to have a section on Halloween, and thereafter it's a big section on gifts for Christmas. And then after Christmas, it will change again. That's exactly what we had to do during the COVID-19 crisis. We had to expand, and perhaps in the things we could have done better, we identified the 4 Ps in this recent article: preparation, progress, personalization, prioritization. But to focus now on preparation, we learned a lot about how to manage the crisis, how to find beds in pediatric ICU, in coronary care units, in operating rooms, etc. So that's flexibility, indeed. Very good example. And it could be applicable, of course, for non-COVID situations. And it was not just a matter of beds, was it? We had also to organize our equipments. We needed non-invasive respiratory support on intermediate care units or even on the floor, etc. So we had to reduce perhaps some form of equipment in some parts of the hospital and expand for other patients. And there was also the issue of personnel. We had people trying to help us, but without appropriate background, training, knowledge, and we had to cope with that and organize. So all of this is flexibility and already, indeed, communication that we will address later. Space, stuff, systems. That was really the essence. And so for the future, this is a slide I made several months ago, but it's all about flexibility. Yeah. Improved bed capacity, using other areas in the hospital, consider silent ICUs in the future, some beds we could open when there is an acute need for more beds, distribution of resources, reliable supply chains, flexible ICU staffing with proper teaching and training. But all of this requires also standardization. Equipment, people, settings. When we think at standardization, we think at device connections, but it goes much beyond that. But already there. This is a paper I wrote several years ago now, saying, in the ICU, already, we need a better integration of signals. We look at cardiac output here, we look at respirator screen there, we look at the hemoglobin level there, we look at the amount of sedative agents there, etc., etc. So, and all of this is complicated by a number of wires. So we know it's not easy for the industry, but we would love to get rid of all these wires, and we will get there, of course, undoubtedly. And then the hospital has become very complex. There are many, many places that need to be better interconnected. This is an image I like, but it's not mine. This is mine. This is how I see our environment with the emergency department, the Department of Intensive Care, perhaps intermediate care units, and interactions with the ward, with the operating room, with the radiology department, where our patients have to go for limited periods of time, but we cannot stop the monitoring, we cannot stop the surveillance of these patients. So even before the hospital, hopefully now, and this is a slide from the pre-COVID era, we already used transmitted images of echography. And of course, this is something that we will do more and more in the future. We can send images from New York and Boston to Munich and back with these telecardiology kiosks, which are becoming available. So this needs communication and interactions. So in the ambulance, AI, artificial intelligence, will already bring us some information before the patient arrives in the hospital. And the systems could establish priorities, propose urgent actions. We'll do more and more in the ambulance in the future, especially in rural regions. And of course, we could have triage decisions. Likewise, in the emergency department, the point I would like to make is that there is a continuum there. When I was young, there was the ambulance coming in, the patient was put there, and the ambulance people were living like that. There was no real continuity. The world of tomorrow will be a world of interactions of continuity. Pre-hospital, hospital, emergency room, ward, ICU, and then the nursing home or convalescence hospitals, etc. And of course, we cannot forget the GP in this setting and the people who will go at the bedside of the patient outside the hospital. I like the American concept of critical care medicine outside the ICU and inside the ICU. In Europe, we speak about intensive care medicine, but thinking about it, it's not that bad to think that our specialty is much larger than the work in the intensive care unit. A number of patients will get worse on the floor, and obviously then we would like to be called before a cardiac arrest. We would like to have what people call a MET team or a rapid response team. I like rapid response system myself. So this is the RRS team, and you can choose the kind of team you want. We had a roundtable discussion on this just 3 days ago in Brussels. So how we do it now is to have a central monitoring system, and we are using such very simple signals, such as respiratory rate, heart rate, systolic blood pressure, conscious level, temperature, hourly urine output. That's the kind of variables that we are using. And like here at the South Florida University that I visited not so long ago, they could even have a graphical way on the floor to identify the patients who are likely, unfortunately, to get worse. And there is a central station in the hospital. There are some scores, like the Rotman Index score. Some people like to speak about early warning systems for sepsis, and then they add some additional information. I'm not sure that we need to separate sepsis emergencies from other emergencies. There are patients who need help, who need action, and sepsis and non-septic patients need the same kind of support. But monitoring systems on the floor, if we think about it, they will change dramatically. And all this information should be collected, kept, and integrated. We will have better respiratory monitoring systems, acoustic monitoring, plethysmography, mask with inbuilt sensors. We will have wireless sensors that could monitor cough, fever, respiratory activity. We could have simple monitoring of ventilation. Yesterday we had a nice talk on how jewelry instruments will help to monitor heart rate and blood pressure. Right now it's not very reliable yet, but it will be reliable. And again, all of this without wire or even without the patients knowing it, because the system will be under the mattress. Did you see this? This is very exciting. It was just reported a few months ago now. These are 48-hour ultrasound recorders. You know, I was discussing with an expert in echo yesterday, and she was telling me, she was agreeing with me that in the future we won't have echo courses anymore because it will be done automatically, like the EKG analysis is done automatically today. So we will rely on automated systems to monitor the cardiac function of the patient. So we wrote this piece recently about critical care without central lines, or with Dr. Michard and Dr. Pinsky on the news, non-invasive ergonomic wireless and wearable sensors and smart software and algorithms. Okay, so if we have different variables, different monitoring systems that can communicate to each other, alarm fatigue can be avoided, because we will integrate these signals into clever alarm rapid response systems. We will not even have to look at all the variables. It will be behind the screen, and we will get the signal. So now we can make a scheme, a drawing of flexibility and standardization with the integrated management system. Being close to the patient or further away from the patient, it doesn't matter, but connected to an alarm signal and to the smartphone or tablets of the healthcare personnel. And if there is an alarm, of course, we will go there right away. The issue is that, again, we need to identify the crisis before the so-called serious alarm, and definitely before the cardiac arrest or the multiple organ failure syndrome when it's too late. So the early alarm system will help to already act before the situation is getting really sour. And perhaps it will give the opportunity to do another imaging test, the bacteriology test. We will call the specialists. This is, how the time course will be now taken into account, and how we will actually predict or at least identify very early any decrease in blood pressure or any increase in heart rate. That's a path to precision in critical care medicine. These are two very recent papers published in Nature Medicine. Wow! On the systems like the TRUCE, and there are others, that could use machine learning-based early warning systems. But to do that, again, we need to have good communication system. This is a paper which came out 2 years ago on early prediction of circulatory failure in the ICU using machine learning. And here, if you come to Rome next December on the meeting on the future of intensive care, you will hear Dr. Liu speaking about his experience with automated identification of adults at risk for in-hospital clinical deterioration. And for those who want to see a decreased mortality rate everywhere, yeah, there was a decreased mortality rate after an alert in the patients who were in the system. So, lots of interactions within the hospital, but also with the outside world. The hospital of tomorrow will have some loose borders. It will not be, in and out of the hospital like some years ago, because obviously we'll have better support systems outside the hospital. When I was visiting an American hospital not so long ago, they told me, yeah, we cannot discharge this patient, there is no room on the floor, but we will discharge the patient home. From the ICU to home? Yeah, we do it from time to time. And indeed, immediately thereafter, it was 4 years ago, I started to see some reports in critical care medicine and elsewhere showing that it was feasible without any harm for the patient, provided that we have a good healthcare system outside the hospital. And this is another report from Stelfox in Canada showing that this is certainly something which is doable if we have good home care systems. And of course, with telemedicine, that's something which will be facilitated. So we will speak about monitoring of patients' home, and we will speak about patient safety needing innovation. This just came out last month in a major journal as well, in Nature Medicine, again, saying that there is a broader need for social discussion on what safety and harm mean in the context of evolving medical technologies. Now we are entering the era of big data, and that's an important point when we speak about flexibility and standardization, because we need to collect enough information to make progress. Cardiac output. There are people who no longer measure cardiac output in the world, in the US in particular. So, no, because we don't know what to do with it. Wait a minute. Cardiac output is a fundamental variable, but we need to interpret it. And we could actually consider where the problem lies and how we could best manage these patients having any alteration in the cardiovascular system. We can have it in an imaging fashion, as I did in this graph. And so when we put the things together, oxygen delivery, SVO2, oxygen consumption, cardiac output, degree of filling of the heart, extravascular lung water, now we start to see the various therapeutic options. Of course, should come in our minds, but artificial intelligence could also make some very valuable suggestions. Remember this paper, again in Nature Medicine, that we spoke about so much 4 years ago from London, showing that an artificial intelligence system can learn optimal treatment strategies for sepsis, decide when to give more fluids and when to give more vasopressors, the questions we are discussing at every single session here. But if we want to have enough data, we need to have a good interaction between the various systems. And this is a paper that just came out from France, from Claire Roger and collaborators, assessing closed-loop system, not only for vasopressors, as we did with Josten and others did, but also fluid. So we could now combine it already, in the operating room, and we could have integrated data for the pre-operative care, the perioperative care, and the post-operative care. And that now brings some information about trend analysis, and it allows continuity of our approaches. Again, people will say, does it improve mortality? The progress sometimes can take place without decreasing mortality. There are so few things that decrease mortality in our field. But that's interesting. It also came out recently from Dr. Scholl, who is an expert on this in Switzerland. He will be in Rome next December also, on avatar-based patient monitoring in critical anesthesia events. And you can see the figure, again, as I indicated. You can have a simple figure indicating where the problem lies. Yeah, we need to integrate multiple variables, as we would do for nutritional support, or as we could do to select an antibiotic, taking into account information coming from the patient, from the hospital, from the environment, and then the computerized system could actually help to select the right antibiotic, etc. And the ESICM as an app now proposing this. It's not so new. This was published in the New England Journal of Medicine 24 years ago. Very interesting, from Salt Lake City, who are really pioneers in this field. So it's not only at the bedside, improved alarm systems, trend evaluations. It's also information coming from various institutions, or at least various sectors of the hospital. Let me just give one or two examples here. Ventilate. When should I intubate the trachea of a patient? Oh, I look at the patient at the bedside. Yeah. But can we help the doctor who does not have the same experience, who is on call at 3 o'clock in the morning or on a Sunday afternoon? We cannot wait for too long with non-invasive mechanical ventilation. We know there is a window of opportunity. We don't want to wait until cardiac arrest, and we don't want to intubate too early. We also learned it in the COVID crisis, right? But when to intubate? We need to take different variables into consideration. If we look at statistical evaluation, we could say, well, late intubation may be better than early intubation, but no, there is clearly no significant improvement. It depends on the patient. It needs to be personalized. And so that's how, since the Surviving Sepsis campaign didn't want to say anything about it because there were no prospective randomized controlled trials on this, we wrote this piece here with a number of people who are present here, saying that there is little leeway for adapting the recommendations to individual patients. So we need to consider different variables and integrate them. Some patients with ARDS may improve rapidly and may be kept on non-invasive support rather than invasive mechanical ventilation. But again, I think that we will learn if we can feed the system with adequate data, we will learn a lot. The study at the top is on prediction of suicide attempts and suicide death following outpatient visits using electronic health records. We need to have electronic health records that we could use. And so this is about extubation. I just spoke about intubation, but extubation, there are also machine learning systems for that. And my very last point is, in our standardization process, we need to have a common language. because the systems will look at different words that will appear in the progress notes of the patient's chart. And if you do not use a common language, then we may be in trouble. So I think there should be an effort for this society and other bodies to try to have the same language. Have you heard people speaking about hypoxia when there is a low PO2 in the blood? Yeah, I have heard it. But it's hypoxemia. Usually there is no hypoxia when there is hypoxemia. But people use one term on the, oh, it doesn't matter, Jean-Louis, this is a detail. No, when you go up to the Everest, of course you have a very low PO2, but look at the lactate levels. There is virtually no hypoxia, no tissue hypoxia. So these are different things, and we cannot just mix them. We need to have a good language of communication. Likewise, altered gas exchange is not the same as a low PO2, of course, but let's use the right terms. And when we speak about mechanical ventilation, we need to put some order there. You know, mechanical ventilation, no, okay, it could be CPAP. It's not mechanical ventilation, CPAP. It's a form of respiratory support without ventilatory support. And if there is mechanical ventilation, it doesn't mean that there is endotracheal intubation. So we need to have this kind of elements in our minds. And then, is the patient on assist control? No, controlled? No, assisted? No, it's assist controlled. It's volume control? No, it's pressure control. But, you know, please, can't we speak about predetermined volume ventilation, predetermined pressure ventilation, and then go from there? It's just an example. I'm not trying to impose what I think is the valuable concept. I'm saying that we need to have the same language, because at the end, the data will be collected from many places. And that's how we will make progress in interpreting this data. So the future, of course, less invasive monitoring systems, smaller instruments, point-of-care testing, flexibility, wireless equipments, standardization between equipments and data, reliable trend analysis, allowing us to have integrated variables, and from there, intelligent alarms. So the future is bright, but indeed, flexibility, standardization are two very important words. Thank you very much. Merci.
Thank you, Jean-Louis. Now I invite both speakers to join the stall and take your seat, so we can start with a discussion on these subjects. I take the privilege to start with. Both of you have diffusely spoken about preparedness, somehow, continuity, artificial intelligence. All these things are fundamental. My question is, all of them imply important financial investment in order to prepare adequately the future. How this can be conciliated nowadays with the cut of the investments that each government has and each healthcare system has to effort. Have you ever any idea or suggestions?
Is this on? Yeah, okay. So I can give some examples from the UK. So before the pandemic, when enhanced care was first starting to be developed, it was done at a very small scale, particular services in particular hospitals, and they would often use a small amount of money to pump prime their service to demonstrate the proof of the concept and to demonstrate that they could make efficiency savings. And from that, they then made the business cases to get the funding that they needed to make it a more permanent service. So that was what was happening before the pandemic. Since the pandemic, because we have so much pressure on our services and because there is such a lot of data out there to show the impact of cancellations on the day for elective surgery, I think a lot of the healthcare services have got their head around the idea that they need to spend some money in order to continue getting patients through, because there's such political pressure for us not to cancel patients at the moment.
Maybe, if I may replicate a little bit, maybe it'll be easier because this context is something that pertains the elective surgery somehow, and then probably can be better optimized, the approach. But as Jean-Louis alluded to, he was speaking about indeed the ICU environment, which is a large part related to emergence, and where predicting things may be practical and possible, but not in the same way in which you have to do when you have a post-op or you have to program the surgical interventions. So what is your idea also concerning investments that I alluded to before?
Yeah, I see the ICU as the real core of the hospital, the real center of the hospital. But of course, the issues are not only in the ICUs, and as I tried to show, there are a lot of interconnections with all the other departments of the hospital, not only the emergency room or the operating room, but the wards and every single place in the hospital. Now, with respect to the financial needs, I am not so concerned about this, because there is clearly a reward. And the reward is the avoidance of complications. If we know better when to intubate a trachea, we will have less respiratory arrest, less cardiac arrest. That bring patients in the ICU for several days before probable death, if the cardiac arrest has lasted for a while. Whereas we could, just to prevent that brings a lot of money on the table. And you could multiply the examples. The patient who is admitted earlier in the ICU can benefit more from this support and go back to the floor earlier than if the patient arrives too late in the ICU. I mean, we all know that. Or patients who go through the emergency room to a regular ward and then come to the ICU because they are worse on the next day. So, okay, all of this can be improved with the systems we will put in place. Now, the problem is that if we go for one system and we put the money in that system, once it is implemented, okay, let's go. There is another system coming in, which is more modern, which is more sophisticated, which works better. And we will have to replace the system we have just bought by the new system. That's the big issue. And that's where hospitals are a bit hesitant to buy a system too early. It's true for any kind of technology. If you buy a car now, maybe next year the recommendations will be different, because with the energy crisis or whatever, with some developments, finally we will change a little bit our attitudes. So that's I think the big issue. You buy something and it may become rapidly outdated, because things move so rapidly that things can become outdated quickly. So that's, I think, the big issue.
But that reminds me also what you alluded to, which is very important, communication. We are in an era, at the moment, where at times even the same radiological systems for reading the chest or the imaging do not speak each other. And you need to upload, making some strange tricks that it takes time. Yep. So communication remains a major issue. Also because the future system, I do not know if you agree, but should be adaptable and modifiable, speaking each other. This is the real challenge, which is difficult to achieve. Standardization, indeed. Standardization of the system. However, from the audience, I have also a question that is for you, and say, what is your view? How can you magic up the necessary staff who needs upskilling to provide enhanced care? This is for you, Daniele.
Okay, so I think staffing is a major issue for everybody. We know there is a global workforce shortage. One of the things that we have found within critical care is a lot of staff went through the critical care experience and didn't want to continue working because they'd been in such a tough environment, but they still have those skills and they still are retained in our hospitals. Similarly, staff came through critical care, enjoyed some aspects of the experience, but again have gone back to their areas that are not critical care to continue working. So I think it's about identifying the staff you have in your hospital that are willing to be upskilled and are keen to be upskilled, and then thinking about where those skills could be produced from in your staff groups. So this idea of transdisciplinary working, so nursing skills aren't just delivered by a registered nurse. Particular sort of physiotherapy skills are not delivered just by a physiotherapist. There's such an emphasis on an alternative workforce in terms of different titles and different skill sets that I think you have to be really flexible about this and not just say, I need 6 nurses for this, I need 2 physiotherapists for this. It's thinking about what skills do I need and where can I get the skills.
But if this is true, it comes out another problem that concerns the standardization at the European level. Each country goes in a different way for the moment and a different track. We need to find out a uniform bench of interventions in order to correct most of the mistakes that has been done up to now. This is not easy because it represents a political issue. And it's difficult to understand how we as doctors, maybe as a societies, but as single doctors may interact efficiently with the politicians in order to change the mentality and to change the horizon with these new important issues that we have to confront with.
Yeah, with respect to the need for healthcare personnel, seen from the ICU perspective, we will need less personnel in the future thanks to the development in technology. And right now we know that personnel costs 70% of our budgets or around that figure. So that's another incentive for the development of new technologies. We will have a lesser need for nurses, for doctors, for physiotherapists, for technicians, and less need for any member of hospital teams. Now, the people sometimes, when I speak about the hospital of the future, they come to me and they say, well, will we still need doctors in the future? Of course we'll still need doctors, but doctors will have more time to talk to the patients and to talk to the families about the plans, about the ethical aspects, about the choices in therapies, etc. So we will have a different life. But clearly, we will still need doctors. But at the present time, on the floor, on the general floor, you need a nurse. What do? Well, you push the button. And when will the nurse come in? Oh, that depends. Sometimes a few minutes, sometimes 15 minutes, especially during the night. That's not normal. I don't know if we have some Portuguese doctors in the room, but in Lisbon, they have this beautiful Champalimau hospital, which is a private hospital that wants to be the hospital of the future. And in each room, you have a big screen, and when the patient pushes the button for help, there is immediately a nurse appearing on the screen. The nurse may be relatively far away, but immediately, what can I do for you? With a bilateral camera, and so we can immediately see if the patient says, I'm sorry, I just wanted to say that, versus, I don't feel well. And the nurse will know how much time he or she can have to go to the patients. So it's not that care will be less good. Care will actually be better because we will be able to put a hierarchy in our responses. Rapid response when it's necessary, and less rapid response when it's less necessary. So we will spend less time on personnel and buy money to put in new pieces of equipment. We may like it or not, that's the future.
Fantastic wrap up. It's time to conclude. I sincerely thank the speakers for these very beautiful presentations and all the audience. Maybe for concluding, we can say that the future is in front of us, and to build up a better future is exclusively in our hands, in our beliefs. Thank you.